let me introduce Michael Cohen. He's been a host on a couple of our webinars in the past, but we have not been able to give him a proper introduction. So Michael Cohen is a sleep industry veteran. He's been in the sleep industry for almost 20 years. Started off as a pediatric sleep technician, classically trained here in Southern California at Loma Linda Children's Hospital, where he used to do in-lab studies for patients, get those reports ready for doctors, and then post that career went into building sleep centers, actually worked in getting CPAP technology approved by the FDA and kind of building some proprietary stuff there, and really worked on the business side of sleep until he opened his own company called Awaken to Sleep. And that's where we are today. Our company is about 7 years old, 6, 7 years old. And it was all started because of a story he'll probably share with his daughter in a few minutes here. So I don't want to steal his thunder much, but Mike, why don't you tell them a little bit about yourself and what you're most excited about for the fall season coming up?
You know, I told you to ask a funny question, but I don't know the answer to that, man. I think it's got to be cold weather. It's got to be cold weather. The fact that we could leave the windows open and actually not die like we're at the gates of Mordor, that would be awesome. So for those of you guys that don't know, you guys, that's not disrespectful. This is the Southern California version of y'all. So we are... we're going to talk about sleep tonight. What am I most interested in? What am I most excited about? I would say the fact that I get to give you all tonight 4 pieces to having a successful program. If you're on this webinar, I'm guessing based on the title and the fact that you're here, you've either tried a sleep program or you've thought about doing it, but you've heard a lot of these stories about how it doesn't work. I'd love to give you 4 very detailed, specific steps tonight so that you can walk out of here knowing more about this, but knowing where to start or what piece broke in your program before. That actually matters to me. So without further ado, I will start this up here. Chad mentioned my personal story. So I guess it's time for the why slide. This is my crew. We love doing national parks. I believe this one is outside of Lassen Volcanic National Park. But we're a traveling family. We love to do road trips. My 4 kiddos there. The one in the teal blue sweatshirt, not sweatsuit, Chad, but the sweatshirt is Anna. Anna was born with reflux. And she actually had reflux that was so bad it was causing her severe obstructive sleep apnea. I don't have a time tonight to get into the whole story, but suffice it to say, there's nothing worse than holding your infant child, knowing that they are turning blue in your arms, not breathing, and there is nothing in that moment you can do about it. But thank God for the people that poured knowledge into me earlier on. I was able to understand exactly what was going on with her from an apnea standpoint. We got her tested. We worked with her pediatrician to get her treated proactively. And that sweet girl is here today when she might not have been, had that knowledge not been given to us. So we're thankful she's here. That story, gosh, how old is she? 13 years old. So 12 and a half years ago, just completely changed the track of my personal life. How it affected my professional life. And as Chad said, I've been doing sleep for quite some time. That being said, I'm here for you. If there's anything that we can do tonight, that I can do tonight, talking about this topic of dental sleep medicine, how to implement it, how to help patients, hurdles that you all have hit, I want to be a resource for you. I mean, throw a hard question in, throw something in the Q&A. As I'm going along, as Chad mentioned, if you put anything in the chat or in the Q&A feature, we will be here tonight until we answer everybody's questions. So this matters to me, both professionally and personally. If there's any way that we can help, we want to. So tag us with those questions. I'll say challenge accepted. Hit us with the hard ones. To get into our topic tonight, number 1, the very, very first thing that I will give you is you got to define your workflow. So out of those 4 steps that we've got to understand to have a successful sleep program, we got to have a workflow. I mean, if we don't have a workflow, all we have is a hot mess. And if you all have tried dental sleep medicine before and you've been struggling with it, you know exactly what I'm talking about. Dental sleep medicine isn't really that complicated. It's a 3-step process. We got to find people. That's the identify part. We got to have a team approach, all kinds of details. We'll talk a little bit about that tonight. We've got to have an approach to finding people, because as you all probably have heard before, the vast majority of patients that have obstructive sleep apnea do not know about it. We're talking 80 to 85% of millions of people in this country have absolutely no idea they have this disease. So we've got to have a method, a scientific approved method to find these people, intraoral signs and patient symptoms on a questionnaire. We've got to be able to talk to them in a way that they will actually get tested, which is our second component, assessment. We have to have an objective assessment, i.e. a sleep test, that's read by a physician in order to get the patient diagnosed. And then the following part is treatment. And that, frankly, is the part that should be the hardest, but is the easiest. If you make night guards, you know how to make oral appliances that treat sleep apnea. Now, yes, there's a little bit of difference, but frankly, with pretty minimal training, you all can deliver these appliances. And the science itself is not the confusing part. It's the workflow, which is why this is our number one step. You've got to define your workflow and how you want to move forward in this process. Now, granted, this is a streamlined workflow. It is not taking medical billing guidelines into account. That would be a subset of your workflow. So we'll talk about the difference between fee-for-service, medical billing, all of that kind of stuff in a little bit. But for now, the bottom line is you got to define what the steps are. At the very least, these are the 3 things that you want to achieve. Finding people that have high risk for airway issues, getting them assessed so you can get them diagnosed, and then moving on to the treatment. Well, how do I identify them? Let's talk about it. Do you have a workflow in your practice or a workaround? A workflow clearly defines who does what. Does your team understand that this is a team-driven workflow or process? You know, this is very different for those of you all that are doing implants in practice. This is very different, almost the opposite of your implant workflow. Because when you start syncing implants, doing single unit cases, multi-unit cases, guided implant surgery, you're the doctor. You're the one planning the surgery in the software. You're the one actually chairside doing the surgery. In dental sleep medicine, it's almost the opposite. We need hygiene to understand that as the patient's trusted advisor, they are the ones that are doing the screening. If you're in a general practice, your hygienist should be the first one talking about airway issues, not you as the doctor. If you have your back office assistants that are going to be your sleep champions or the folks that step up to do the back office chairside component of this treatment, you almost start treating this process like an orthodontic treatment plan, where you round on your team who's doing the work, and most of your time is spent in the initial consult. That's a workflow, but teams have to be calibrated for that. Your team has to know what their role is, how to do that portion of the job, and then how to hand off. So each person in the process needs to understand their unique piece. That's what we mean by defining your workflow. It's not just your time and your job as the doctor. It's how does this implementation affect the rest of your team? That's a big deal. As we move on to the assessment, again, we're still defining our workflow. The first part is identify. The second part is assessing. How do we get these patients tested? Well, it's not just as simple as asking which tests do you want to your patients. We've got to know first, what tests do they need? If you're looking for airway issues, snoring, possible obstructive sleep apnea, maybe sleep bruxism, well, those patients could pick between a home sleep test or an in-lab test. If for some reason you're referring a patient out because they have a sleep eating disorder, where they wake up in the middle of the night without waking up, make dinner, eat the whole thing, wash the dishes, and go to bed, that's outside of your scope, just so we're on the same page. So if we're looking for a neurologic sleep disorder, they've got to do an in-lab test. Home sleep test, airway disorders. obstructive sleep apnea, primary snoring, possibly sleep bruxism. So we got to know what we're testing for. Then once we go through the testing process, what's the typical end output of that test? If you all have referred patients to an in-lab sleep center, you know that most of them end up on a CPAP. That's because the sleep center is geared towards getting patients into CPAP as quick as humanly possible, because that's been the gold standard of treatment for decades. But if your patient walks in wanting an oral appliance, that's going to be a problem. On the contrary, if you have a home sleep test or you're looking to purchase those, there's all kinds of options, but we've also got to know that end output. The patients sleep at home. Yes, we understand that. But who do they consult with? You, after the home sleep test. Once that consult happens, what's the end output? Do they want an appliance? Are they a candidate for it? We've got to know those pieces. So in the assessment phase, you really have two methods of assessing: in-home and in-lab. Which one you pick depends on which one the patient needs first, neurologic or obstructive sleep apnea that we're looking for, and beyond that, what's the end output that you're looking for? Does the patient want to go with a CPAP? They should probably try an in-lab test. If they want to do an oral appliance, doing a home sleep test where they consult with you as the dental professional after a physician has read that test is probably going to be your ideal. So you got to know what you're looking for and what the end output needs to be.
Hey, Mike.
Yeah.
We've got two questions. One says that someone heard that they cannot order home sleep tests as dentist. And the other question is the accuracy. Is a home sleep test really appropriate, or should they always do, that polysomnogram?
Okay, two completely different questions. So first one is, I've heard that I can't order a home sleep test. Is that true? Is that correct?
Yes.
Okay. So the answer is, this depends on your dental board. Now, I can tell you that if you're in New York or New Jersey, you absolutely cannot order a home sleep test under any regard. If you're in the state of Georgia, Georgia's done something a little bit different. They say that you have to refer to a physician who's going to order the home sleep test. So you can't order it. But once that physician orders the home sleep test, you can actually hand that test out to the patient. So basically, they want the physician to be involved in that process. So it depends on the state that you're licensed in. The vast majority of states do not restrict the dentist license in the ways that I just mentioned. And the ADA, the AADSM, American Academy of Dental Sleep Medicine, last year during COVID, came out with an official position statement saying that their recommendation is that dentists do own and operate home sleep testing equipment so that they can get patients seen quicker and manage this workflow better. Chad, there was a second question in there. Sorry. It was, accuracy. Is
Yes,
that right?
That's right.
Okay. Home sleep test versus in-lab sleep test. The first question most people ask is accuracy. Are they equivalent? Are they as accurate? The answer is yes. Home sleep tests, based on the newest devices that are available and their FDA clearance, those tests are channel to channel as accurate as an in-lab sleep test. When we talk about accuracy, we want to have greater than 90% accuracy channel to channel for each thing that's being measured. And that has actually been the case. The difference is what we're measuring. In a home sleep test, you don't have all of the channels, i.e. the wires that are on the patient's head. And when you don't have that many channels, you don't have the data from those channels. So if you take a step back from being so deep on that clinical piece, patients that have a neurologic sleep disorder need all of the wires and channels on their head, because we need to see all of the details of their sleep stages, what part of their brain is acting up, what's going on in that process for that neurologic sleep disorder. Obstructive sleep apnea is an airway or physiologic sleep disorder in the patient's airway. So we're not dealing with a neurologic one. All right. So I'm going to poll the audience just to make sure in the first 15 minutes or so I haven't put you all to sleep. Who here, if you can hit me in the chat with just 3 letters, HST, PSG, or not me, I don't know, How many of you have had a sleep test? Was it a home sleep test, HST? Was it an in-lab sleep test, PSG? And not yet. Let me know. I got one nope. Not yet. Okay. Okay, somebody's dad had an in-lab test. Got it. All right. So a lot of no's. All right, friends, if you feel like you're at risk of an airway issue, we can help. Oh, Maria's had an HST. Okay, so if you haven't had a sleep test and a doctor, your dentist, or somebody sat you down and said, hey, I want you to do a test. What do you want to do? Probably a home sleep test. But what you really want to do is the test that you need, not all the other tests that you don't need. So that's where we bring it back to the core. But I will say this from a patient perspective, if our goal is to get people to take the next step that we ask them to take, and you're in the screening conversation and want them to move forward with testing, reducing as many barriers as possible is the best route to go, because you'll just get more people that move forward with it. More people say yes to a home sleep test versus an in-lab. So if we can do a home sleep test and it's clinically appropriate, we want to do it. If it's not clinically appropriate for whatever reason, we shouldn't do it. We should refer to an in-lab. All right, I'm going to move on here. Once we've got a patient screened and then diagnosed, the last step is treating them. Now, like I said, this is probably the part of the process that you're not so concerned about, but let's talk about it. Treatment plan options for obstructive sleep apnea include all of the following on the screen. You've got surgical intervention that can happen from oral surgeons, from ENTs, general surgeons. You've got CPAP, which is the gold standard. There's a recall in place, and we should talk about that, but there's CPAP devices. They blow air in, they create an air splint in the airway. The biggest problem that patients have with CPAP is the air, but that's the thing that's doing the work. So we have a gold standard that has a really low adherence or compliance, and that becomes a problem. Now we've got oral appliances, less invasive than surgery and CPAP. They're the #1 recommended treatment, or the dual primary recommended treatment for mild and moderate obstructive sleep apnea. That means your patients can move right into oral appliances from being diagnosed if they're mild and moderate. If they're severe, they need to try CPAP first, and then if they fail that, they can come back to an oral appliance. Now, most of you all probably don't talk about doing nothing as a treatment option, but we strongly recommend it. We actually have a component of the courses we put on that specifically talk about how to get the patient to take doing nothing off the table, because it's the most expensive thing they can do. All of these things affect their lifestyle. Doing nothing will actually affect their lifestyle most out of all of them, but we need to understand that in how we're connecting to patients. So that's a big deal. A couple other things to note before we move on from the treatment. Dentists, according to the ADA, dentists should be screening for OSA, or airway concerns, and they should be working with their physician counterparts. So i.e. in this discussion, we talked about a home sleep test, going out to the patient and having a sleep physician read it. That's working with your physician counterparts. Referring to an in-lab test that's read by a doctor, that's also working with them. So the ADA said dentists should be screening for this. Last year during COVID, the AADSM came out and said, hey, if the CPAP machine spreads this and aerosolizes it, then you know what? We should probably push oral appliances first, not just for mild and moderate, but for severe as well. This is a position statement by the AADSM. This is not a payment guideline or an AASM guideline. But if we can see what's going on in the industry, just a quick snapshot, oral appliances are not rogue. This is mainstream. This is a dual primary, or an equal opportunity for patients treatment-wise for mild and moderate OSA. This is a big deal. So you're not going rogue. This isn't fringe. This has been around for a couple of decades now, and it's an accepted form of treatment. And it's one that our patients really want. Most just don't know about it. So it's worth having that conversation. All right, hard right turn. We're going to move into evaluating our technology. So how does our sleep program work? What's the first step in getting this off the ground? Number one, we've got to define our workflow. What does that look like? Who's involved? Our team, all of that stuff. Now we make a hard right, and we're going to talk about your tech. What stuff do you already have in the practice that can be working for you? Well, if you have a cone beam and you have an airway field of view, meaning you can catch the posterior portion of the hypopharynx, you're on the money. That means you can use your CBCT and the color coding component of the software to segment the airway and show the patient a picture of what it looks like. Now, I'm going to be very, very clear right here. Cone beam is equivalent in your sleep workflow to screening. You can use it to screen your patients. Patients who are going to be diagnosed with obstructive sleep apnea have to be asleep to show that they have sleep apnea. So this is just a screening tool. But frankly, a picture is worth 1,000 words, and patients naturally gravitate towards pictures like this. If you pulled this airway scan up in front of a patient, what's the first thing they think of? Well, if they're skeptical like me, it's, is this actually my scan? If they're not as skeptical, they're going to say, hey, why is that thing right there highlighted in orange or red? That doesn't look good. Is that right? That's the natural tendency to have that conversation. So great. If you have cone beam or you're evaluating cone beam, if you're looking at cone beam and you're going to do sleep, make sure that the cone beam you're looking for will catch the posterior hypopharynx, that area behind the base of the tongue, so you can see the full picture and segment that airway. If you already have this tech in your practice, evaluating where this belongs in that process, huge. When do you take scans? How do you use them? How do you talk to patients about it? If you have the tech, you might as well use it for your program. Definitely have that conversation with your team, or if you're looking to purchase it, talk to your rep about what your options are. All right, next thing, CAD cam. Well, the CAD, not the cam. The CAD part. If we're going to do intraoral scanning and we have one of these amazing scanners in the practice, it's going to save you time and money on your supplies to do an upper and lower arch scan. Now, the cool thing is with all of these appliances that are available today, you can actually send digital scans, upper and lower arch, and a buccal plate scan in the protruded position into a lab and have no physical material with that order. Most of the dental labs that we work with and recommend for sleep appliances will accept your order online, and you just upload your STL files from these types of scanners. So if you have a CAD CAM system or you have an intraoral scanner in your practice, look at how you can possibly use that to save yourself time and money in the treatment portion of your process for sleep. The last piece, home sleep tests. I mentioned that the patient has to be asleep in order to be diagnosed with sleep apnea. That makes sense. Well, are they going to a sleep center or are they going to their home? If you're looking at evaluating home sleep testing equipment, you want to make sure, one, that it's FDA cleared. For sure. Number two, you want to make sure that it's going to fit your budget. What I mean, there are multiple sleep test units out there varying in different prices. Varying in different prices for the unit. Additionally, there's a whole list of supplies with some units that you have to purchase per test. Those per test costs will range from $6 all the way up to above $100 per test. So you're really going to want to look at a testing unit for how are you going to use it in the practice? How frequently do you need it to go out? And what is the total cost of owning that unit as you start evaluating your per test cost with patients? So in summary for your tech, cone beam is screening. Home sleep tests are diagnosing and getting the patient diagnosed by an MD. Intraoral scanners are going to be part of your treatment plan. Each one of those pieces of tech is optional, but can definitely assist with the efficiency of your program. So that's why evaluating your tech is the number 2 thing that you need to look at as you're looking at implementing a successful sleep program.
Hey, Mike, got a question or two.
Yeah.
Specifically on scanners. The question, sorry, I always want to add flavor to it. The question simply is, does having a scanner save you money on the lab bill for the appliances?
Great question. The answer is with most labs, yes. If you send in your stone models and your PVS or alginate impressions, they will actually, for most digitally milled appliances, they will have to charge you, I believe it's a $40 or $50 fee, because they're going to handle all of the scanning in their, in the lab prior to making the appliance. So yes, there's typically an upcharge if you're sending in stone models and PVS or alginate impressions. Cool.
And then another question was, where can you look for home sleep testing equipment? Who sells that?
Awaken to Sleep is working with all of the dealers who graciously invited you to this webinar. So if you all are interested in home sleep testing equipment, I'd connect with your rep that invited you here. And beyond that, at Awaken to Sleep, we have sleep coaches that will actually have a conversation with you about what unit would fit your practice or your workflow. So you can talk to your rep about getting a complimentary consult to discuss that if you'd like.
Cool, that's it.
All right, we'll keep going. We're on time so far, which is not my normal. All right, so when we come to the testing part of this, so we talked about home sleep tests, in-lab sleep tests. I want to focus a little bit more on home sleep testing because there's a couple of ways that you all can do this. And I want to make sure that you know about the options that are out there. So if you're leaning towards the home sleep test, let's figure out what that workflow could look like. Well, the first one is what we would call an in-house home sleep testing model. This means that you purchase the equipment, you have to own the cost of the supplies as the unit goes out to patients. If you own and operate that equipment in your practice, it's going to do several things for you. As the list mentions here, some of the highlights, it's going to give you a faster workflow. In the workflow where you have a home sleep test unit and you work with a company, say like ours, that has a panel of sleep physicians ready to interpret your test results, you're looking at a 1-week time span between screening the patient, getting them tested, and having the consult to get them into treatment based on their diagnosis. That's a 1-week turnaround, which is incredibly fast. They likely cannot go see their primary care physician, let alone a sleep specialist, within a week's time. Typically, depending on your area, it's going to take weeks to months to get into those folks. Second, it's going to give you control. Now, in the state of Georgia, let's play devil's advocate here. If you're in the state of Georgia and you cannot order this test, why on earth would you buy the equipment? Well, you can work with either one of our docs via telemedicine or a local PCP. And once that doctor orders the test, you can hand it out immediately to your patient. Second benefit that's not on the list here, because this is about diagnostics, but just a secondary benefit, you're going to need testing equipment in your office when you are titrating patients in their treatment plan. When you deliver a mouthpiece, it's going to be in the starting position, not the ending position. And as you go through the process, it is incredibly efficient and cost-effective to have your own equipment to test that patient incrementally in that process to see when they are at their ideal position. Once you achieve the ideal position, you have a physician read that last test result and you refer them back to their primary with a bow on top saying, here are the 2 sleep tests. This is the results and this appliance is working. Please send me more cases. So those are the pros, a lot of them. Some of the cons, you got to buy the equipment. So there's an upfront cost that is different than referring out to a service, which we'll talk about here in just a minute. Outside of that, it really is just about your equipment being broken. Candidly, that's a patient problem. It should not be your problem. We do. Yes, we do. So we have a patient intake form here. This is a sample by Awaken to Sleep. This is something that's in our online platform, but if you want to take a screenshot of this, you want to hijack the verbiage, you are 100% welcome to do that. The bottom line is, if you hand out equipment to a patient and you're supposed to get it back and you don't, or you get it back and it's in 22 extra pieces that it wasn't in before, that should be on them, not you. Now, that's not a Hallmark card and saying something nice. They should be signing with a credit card on file saying that if I bring it back late, broken, or I don't bring it back, here's exactly what I owe you. Steal this, use it, please cover yourself. If you have equipment already or you intend to buy it, this is a huge benefit to your practice. Nothing goes out of your practice before something like this gets signed. Okay. Now let's say completely separate model. You don't want to own testing equipment, but you want to refer out for the home sleep test. You still like the home sleep test model, but you just don't want to own the equipment and you want to refer it out to another company. Some of the benefits to that, well, you're going to save yourself some money on the front end because you don't have to own equipment. You don't really have much risk in that process because it doesn't matter if it works or not, you're just referring people out. It doesn't cost you a whole lot except for your time. One of the issues with that is that you're going to have a lower patient acceptance rate. Now, Awaken to Sleep has been for 6 years a testing company. That's actually back to our roots, how we started. When we received referrals and when companies across the industry receive referrals from dentists, from physicians and elsewhere, there's about a 50 to 60% failure rate on those referrals. If you think about it, how many patients do you refer out to an endodontist or an orthodontist or an oral surgeon? You hand them a card or you send paperwork to that specialist. How many people go? Versus 6 months later, when they come back into your practice, you're like, hey, how did that consult go? Yeah, I don't know, I got busy. Okay. It's the same thing here. So though there's less cost here, there's also less throughput. So where in a conversation where you own the equipment and hand it out same day, maybe you get 8 out of 10 patients to say yes. In this conversation, just give yourself some grace there. You're probably at best going to get 4, maybe 5 to get to the point of testing if you refer them out. No cost, less risk, less throughput. And that's part of the process. Additionally, your patients are going to have a slightly higher hurdle, not a big one, but let's say you, for industry average, you're charging between $140 and $200 for a test that you own. The patient can't get that test that cheap, even through their medical insurance, likely. If they have a PPO, they can't get it that quick or that cheap somewhere else. But if you refer them out, $140 to $200 if you own it. If you refer them out to a service, that service is likely going to charge, well, we charge $347. So we're kind of in the middle of the range. So it could be anywhere from $300 to $500. It's a little bit more, but it's also a hurdle for patients. So if we know what we're getting into, we know how to move forward in the process. So deciding on your testing protocol is going to be your third step in having a successful program. And I'll be honest with you, there is not one right way to do this. This is very, very important to hear. There is not one right way to launch your dental sleep medicine program. You're launching. You're going to make mistakes. Your team is going to make mistakes, and that's absolutely okay, because that means that we have action. No mistakes equals no trying. There isn't one way to do it. If you start off with the third-party model and you've tried that and it sucked and you couldn't get people to test, this is what we've heard from other clients, then move into the testing model and start handing out units under the dental license in the way that you can. Most of you can own these and just hand them out to patients as you see fit. If you happen to be in Georgia, no problem. There's solutions for that. We can help you. But no matter what you decide to do, make sure that you go forward and just do it and lean into it and get patients into the process. Your passion and help with them will actually propel them mostly through that first step. If they see the value and they connect with your passion, it's going to help them significantly. So if you have the financial bandwidth to bring the testing in-house, obviously it's going to be cheaper for patients and you have higher throughput. If you can't quite get there right now, that's okay. You can lean into a third-party testing company. If you have questions about either one of those, like I mentioned, We have sleep coaches on our team. We'd be happy to help you all out and just understand what you're getting into and how to navigate that. And that conversation's free. We just want to help you out and get you started on the right track. All right. Oh, I got a question here in the chat. Or in the Q&A, who already owns equipment? If you can put that in the chat. Do you already own an HST? And have you ever referred out for a test? So that's my cue to ask you those questions, but I want to know, do you own equipment or have you ever referred out for a test? You just put it in there. I'd super appreciate it. While you all are responding to my question, I'll say something else. If you already own equipment, let's say you own your sleep test equipment already. You went to a course, you bought a unit, it's been sitting in a drawer. Talk to us. We'd be happy to help you out with that. I got some yeses, some nos, and a yes and no. Christy, we'll help you out, girl. So yeah, if you already own equipment, you can definitely use that equipment for or with an interpretation service like what we just discussed. So it's not all for naught. If you don't own equipment, you're evaluating it, figure out which model works for you. No matter what, getting started in this is the most important piece. And that's just a core component. All right, last piece, home stretch for tonight. We got a plan to get paid. We don't need hope to get paid. We need to plan to get paid. And I can't stress that enough. If you've heard that sleep is not the right thing because you can't get paid, that's a failure to plan, in my opinion. And this is the only thing I've been doing for the last almost 2 decades. So just suffice it to say, if we can plan to get paid, we can plan to succeed because we know exactly where we're trying to go, we can absolutely get there. It's not a hope, it's not a whim. And I'm not telling you that medical insurance is great or not in your area. I am telling you that you can plan to get paid and make sure that happens every single time. And it is actually pretty simple. So let's walk through it. I'm going to give you some highlights here. First thing, when you are building your fee, please remember to pull in these 3 components. National averages for fees. Let me give you some numbers right now. The bookends, the outside ends of the bell curve, you're looking at $1,800 on the low side and $6,000 on the high side. If you look at the inside of the bell curve that we see as the sweet spot, $2,800 to $4,500. So 18 to 6, 1,800 to 6,000, 2,800 to 4,500 is the inside of that bell curve. Now we coach practices all over the country, and inside that sweet spot of a bell curve is where most practices reside in their fees. We have zero intention of setting your fees. Please set your own fee based on your own practice, costs, and your discretion. But with that said, knowing national averages is helpful. Knowing your true cost of treatment, which I'll show you here in a minute, is valuable. But the number one thing that you need to not overlook, spend time understanding the value of this treatment to the patient. It's not just gonna make them healthier. The fact that this can make them feel better is actually significantly higher on their value scale than being healthier for most people. All right, enough of the hallmark stuff. Let's get into the numbers. What is your true cost of treatment? Well, let's look at it. If you value your hour at $700 an hour, and I say in a calibrated workflow, we need a half an hour of your time, because the calibrated team, the ones that's trained and understands their role, they're doing a lot of this work. Doc, we need a half an hour of your time. That's $350 in cost. Then we've got about $100 in cost on a home sleep test, because that one's going to have a couple of sets of disposable supplies and 1 physician interp. This is based on our pricing of $79 per interp. So just take it on face value. It could be a little bit more if you go somewhere else. $350 for your time, $100 for the home sleep test. It doesn't cost you anything to do a revolution with the cone beam. If you already paid for it or you're making payments on it and it's there, you might as well use it. If it's not, that's a different planning conversation for the future. The oral appliance, Average is about $500, 5 to 6. Okay. There are appliances go all the way up to $800. There's ones that go as low as $400. So right there in the middle, you're looking at $500 to $600 in cost. Total that all up for your time plus lab bill and materials, you're looking at just under $1,000. Now, if you go to the other column and look at the payment side, we're not talking insurance. We're just talking payments from patients. If they paid you for the exam, call it $100, $200 for the home sleep test, $250 on average for the cone beam. Total, $2,800. That's the low side for the appliance. $3,350 total treatment costs. So even if we put all of that into the $3,350 and we don't charge each line separately, that's okay. We'll talk about that here in a second. But again, within the bell curve, $2,800 to $4,500. If you're in that range for your total treatment plan, that's the sweet spot across the nation. Engage it up or down based on your neck of the woods. That's your call. But at $3,350 and a $950 cost, you're looking at $2,400 net margin on a case that took you 30 minutes to complete. I would argue that that's probably time, like hour for hour, dollar for dollar, one of the most valuable treatment plans that you can have in your practice because it's team driven. If this took you 3 hours, that's a different conversation. That's probably why some of you, I'm guessing, if you've tried sleep, you've been a little frustrated because you're wearing all of it on your shoulders and you don't have to. So in a practice that's one hygienist seeing 8 patients a day, 4 days a week, 128 total patients in a month. If we have an 80% screen rate, a terrible testing rate, I mean, these numbers are the most pathetic that we've seen, period, not what's expected. But if your testing rate is terrible and you only test a third of the patients that you screen, and you've got 25 patients that are diagnosed with OSA and you only treat a third, so your close rate on your treatment plan is 33%, you're going to treat 8 patients a month. The total net profit on 8 patients a month in this model is just under $20,000 a month in net revenue. That's insane. Now, let me be clear. I do not in any way expect that you all will start your program and just ramp up to 8 patients a month. That is not the case. But let's be clear. If you did 1 case or 2 cases a month and your net revenue was, let's say 2 cases a month is $5,000 a month in net revenue after costs, after your time, is that something that you're interested in? Now, beyond all of this, we really care about people first. People first, money follows. How much is this going to impact that patient's life? How much is this going to impact their family, their health, how they feel about themselves, the energy they wake up with, the fact that they're not on track to get hypertension and diabetes, all of that stuff. I mean, that's the main thing. But this is the implementing your program talk. So we got to hit the numbers. If these numbers make sense, then we got to figure out how to get there. Like I said, it's the plan to get paid, not the hope, not the whim, not the I think we got a plan to get paid. And there's absolutely no reason we can't do that. So how do we actually do that? Well, let me show you something that we've put together as a team that has actually worked really well in the practices that we are working with and coaching, the comprehensive treatment plan. So in a situation where you are billing insurance in a dental practice, in a medical practice, if you're in a dental practice billing medical insurance, you are line iteming every single thing that you do. Your exams, your home sleep test, your cone beam, all of your adjustments for appliances, the appliances, all of these things, you're going to line item, line item, line item. And patients are used to that. However, if you have sold anything cash in your practice, fee for service, let's say you're a PPO practice, patients typically pay for what they want. They figure out a way to pay for it. If they're missing number 9, that's a huge pain point for them. They're going to figure out how to pay you for an implant and the crown that goes on top, or they're going to pay you. They're going to figure out how to pay you for that partial They need to fill that hole, literally. They are going to pay for what they want. The main thing here with sleep is so many people have no idea that they're suffering, and there is hope beyond that. So let's just talk about this. On a comprehensive treatment plan, we just discussed in really minimal detail the fact that you all are going to do a case initiation and overall planning for this patient. You're going to select the appliance, you're going to review their scans, review a home sleep test with them, all of these things. This is part of your plan for this patient. The second bullet point there is you've got an oral appliance that you're going to give a 2-year warranty on. If you're okay with that, if you're not, take it off. It's fine. But your oral appliance coming from the lab is going to have a 2 to 3 year warranty from the dental lab. Why not just extend that to your patient? Huge value. You're going to have all the adjustments included in that. So if they need an adjustment in 18 months, you're going to do it for them because they're already there in your practice for their hygiene visit. It doesn't take a lot to do that adjustment. You're going to have titration visits or tests that you're going to see, like I said, home sleep tests that you add in through their treatment process. And then the last thing is an efficacy home sleep test, where you actually have a physician read that test to demonstrate effectiveness of treatment. That's a big deal. All of these things and whatever else you add in there, if there's a cone beam that's in your treatment planning process because you used it to screen, you should add it in here. If you're going to do anything else for the patient, you should add it in here. Every single thing you do should be bullet pointed out, and your treatment coordinator in the front should have detailed explanation about everything that's included here. Docs, I'm going to give you a recommendation. If you are quoting fees and you have someone in the front who is capable of quoting those fees, step back, really emphasize the clinical, and hand off to that person. Because in tandem, working together, you can push significantly harder or more appropriately on the clinical side and your care if you don't then have to ask them for their money. It's been our experience. If you're great at selling, then just tell me I'm wrong and that's okay. But in general, if you can separate clinical and the financial and let your treatment planner who's skilled at that conversation do it, you will do better work as the doctor and they will sell more cases for you. Now, on this treatment plan, one other thing I got to bring up before we move on. There's default financing options on the bottom. Now, some of you might be thinking, oh my gosh, Mike, you've lost your mind. 24 months of third-party care credit, oh my gosh, financing. That's so expensive. 17% is the typical average we see for care credit at 24 months. You know it's more expensive than 17% at 24 months? A no from a patient who can't afford it all in full today, or in 2 payments, or in 12 payments. The reason why we have financing all the way out to 24 months is it makes that 24-month monthly payment equivalent to a cup of coffee a day if your treatment plan is $3,500 or less. That's insane. We need to take figuring out how to pay for it off the table as an issue. If we can help anyone within any realm of appropriate reason be able to afford this treatment plan, money all of a sudden doesn't become the obstacle. It's creating value in the treatment plan. Now, I know you can hear me say this on a webinar, but folks, we've seen this day in and day out in practices. If you can build value in the treatment and help them understand, this is where I'm going with this. This is how I'm going to feel better. And this is why it's good for me. They'll figure out how to make the monthly payments. They will, because they do all the time in other practices. So there's a lot of methods to be pulled out of this and best practices to use here. Again, if you like this, take a snapshot. You're welcome to edit it, steal it, use it. If it helps you get to a yes, we are absolutely happy about that. But if you want to move forward in your process and get more people to say yes, you got to give them some options. We recommend doing this very wholeheartedly. All right.
Mike, we do have a question.
Okay.
Basically, it is what about medical insurance? And could you repeat the fees, the range?
Yes. Okay, I'll repeat the range first and then talk about medical insurance. So the fee range, $1,800 on the low side, $6,000 on the high side as the bell curve. On the inside of that bell curve, more like the sweet spot, $2,800 to $4,500 total treatment plan cost. That's in this comprehensive treatment plan. Not nickel and diming people, just telling them what it is. Here's the way that we can help you afford it and move forward. All right, medical billing. We're going to say this before we move on into our kind of final summary for tonight in the last few minutes. Medical billing, you line item everything out. Every single thing has a code that you have to bill. Every single CPT billing code has ICD-10 diagnosis codes that have to attach to it, and it will drastically change your workflow. When I first talked tonight about that 3-part workflow, identifying, assessing, and treating, that 3 steps. If you screen a patient and you want to go through their medical insurance, you're going to have to send them to a physician, telemedicine or live. They're going to have to prescribe the home sleep test. The home sleep test gets handed out, interpreted by a physician. The RX has to come back for an oral appliance. You wait 30 to 90 days to get a prior authorization for that appliance, which still isn't a guarantee of payment. It's just your permission to deliver the case. And then you're going to go deliver the case and submit a bill to medical insurance. They have 30 days to process your claim and submit something back to you in writing, whether it's rejected, accepted, or we want more info. And then beyond that, you're probably looking at roughly 60 to 90 days to get paid, sometimes longer. So if you are out of network, and let's say you set your fee at what you feel is appropriate, let's call it $3,500, and you submit to the medical insurance out of network, they have the right, based on their analysis, to drop it to an allowed amount. So this is your billed amount, $3,500. Your allowed amount might be $1,180 or $1,250 or $1,900. Whatever that difference is, they're only paying 50% or whatever that looks like off of the allowed amount. So now we've got it dropped down further, and the amount that they are willing to pay is only after the patient's deductible. So let's say if you're at $3,500 and they drop it to $1,950. That whole $1,950 will be paid by the patient to you if their deductible is higher than $1,950. So in most cases, we see with PPO patients, except for maybe in the last few months of the year, most patients will actually have to pay you cash in the first place because of their high deductible plan with their PPO insurance. Now, disclaimer, that's not all plans, that's not all medical insurance companies, that's not all patients, but the vast majority of people have a higher than $2,000 deductible on their plan. Most of those patients will pay you the majority of your fee in cash, just as part of their co-insurance, rather than paying you up front. If we can get people to say yes on this treatment plan, even if it's at payments, and that is a significantly easier thing to do. So I'm going to make a pretty bold statement here. Don't unfriend me before you understand why. Please, if you haven't done medical insurance and you're looking at starting your sleep program, pick one. Don't try to do both. If you're trying to do medical billing right out of the gate and implement your sleep program, it's likely going to break things because medical insurance is complex. Sleep doesn't have to be. We would strongly recommend that you start your sleep program first, figure out those hurdles and get your efficiencies in line, and then add the complexity of medical insurance if you need to. Keep a list of everybody that tells you no, basically. And if that list is big enough, go look at dealing with medical insurance. Either way isn't wrong, but we'll tell you, if you're just starting your sleep program, start it, get the things, the tools, the help, the coaching, the teaching, whatever your team needs to start, and then evaluate it in 6 months, minimum 6 months. Launch your program, see how it goes, and then see if medical insurance belongs in your practice. If you already know how to bill medical and you're doing it for surgeries and imaging and all of these things, then maybe you're on the flip side and you already know how to do that, and this just weaves into that process. That's a totally different implementation. But for the rest of you that are not in that boat, start sleep, then look at medical billing later. All right, getting off to your fast start. We got a couple more slides here I want to get through really quick. Getting off to a fast start, basically, this is your launch success. Find your first dozen or so, 10 to 15 patients that need a sleep test. If you own a test and you're going to buy one, or you own one already, man, reduce that price down to help those folks. Get them a test, whether you have to use a service, get them a discount code, something, get these people tested. This is your first group. Then after that, offer them a discount on your oral appliance. So you pre-identify your select people, team members, spouses, friends of the practice. Find your first dozen or so. Then when you found them, have the conversation and get them tested. Drop their fee, help them out, get them tested. And then sit down with those folks and talk to them about a discounted treatment plan option. Do the oral appliance, do it at a discounted rate. Don't lose your shirt, and don't do it for the lab fee. That's not appropriate. You're going to spend plenty of time in these cases. Make your fee, your lab fee, plus some for your time. But maybe you cut your fee in half or by 25%. Huge value to these first handful of patients. Here's the reason. If you can do this a bunch in your first handful of months as you get going, you're really going to see success with it long term. If you do one patient here and one patient there, every time you do it, it's going to grind, it's going to break things in the practice, and you have to learn it brand new every time, and that sucks, and it takes you a long time to do that. Don't do that. Get a bunch of folks that you can help, get them through the process, and move forward. If you could do 3 things from today, here's what we'd recommend. Set your fee, get your team in, figure out what they need. Do they know their roles? Do they need a course? Do they need help? What do they need? Is your team fully calibrated and all they need is for you to get out of the way? Then you should get out of the way and let them go. Set your fee, get your team in, and figure out exactly what your workflow is in your practice. Hygiene hands off to who after they screen? Who's handing out the home sleep test if you own one, or are you going to own one? If not, if you refer out, who keeps track of that stuff? Who is in what role? Who's doing what? And how do you track these patients? That's your workflow. Set your fee, get your team jacked up and excited about this, and then define your workflow and who's doing what. If you can do those 3 things, you're going to rock it. And you're going to make mistakes, and that's totally okay, because mistakes equate to action. No mistakes is no action, and that's no progress. So we got to move forward together. All right. Last slide here before we hit the Q&A, because we're a couple of minutes past time. Thank you all for the grace in that. We have, through our dealer partners that invited you here today, everybody gets a $200 discount on our upcoming course. So that's September 24th and 25th. You can go to that website, wakingtosleep.com/events. We have more dates than that. If you need a discount code for one of those dates, ask your rep. They'd be happy to help. The bottom line in this course, you get 3 instructors. You get yours truly. I hope you didn't hate me tonight. You get Chad, who talked to us earlier and introduced me. And then we have, in September, we have Dr. Mona Patel. In October, we have Dr. Greg Manning. 2 amazing clinicians. We have fun for 2 days, Friday and Saturday, and it's 14 CEs total for 5 people. So $397 gets you and 4 team members into that course, 2 days, 14 CEs for everybody that registers. I think that's like $5 per CE. It's stupid cheap. Guys, we want to serve you. If you want to do sleep and you really want to know more, this is how we do it. We can get everybody on a virtual course. It's on Zoom. You can tune in from your home or your lobby, get your team invited, and let's get the process going. So if you're not ready for a course and you want a consult, talk to your rep. They can get you a consult with a sleep coach, answer any of your burning questions that you're not willing to ask tonight. I see Mr. Wooters populating our our CE link. So I will say this, CEs are available. The link is in the chat. Click on that, 27 seconds, fill it out, get your CEs for tonight. And we will be here as long as you all have questions. So Chad, hit me. Do we have any questions? Folks, if you have any questions and you haven't asked them yet, go ahead and come on, throw them in the chat or in the Q&A.
Yeah, first, I just want to also wrap up and say this is our last dealer sponsored webinar for a little bit here. So in the email that you guys will get at the end of today, you will actually also have a button to schedule a call with coach. So that link is going to be available to you in your email with the recording and the CE and things of that nature. So look out for that. That should be in your inbox in the next hour or two. And then questions. So one of the questions we had was going all the way back to the sleep testing was how can we try a home sleep test?
Chad, do you have an answer to that?
Yeah, I do. So if you want to try a home sleep test, whether you want to try our third-party shipping model where you get a home sleep test ordered to a patient, or do you want to try one of the pieces that your dealer works with us to provide to you, just use that button in the email or respond to that email you're going to get later today, and just let us know that you want to, and we'll get you a discount. I'm not sure what it is, maybe a couple $100 off, like 150-ish. So you can get a test, try it out, see what the experience is like, and be confident in the process. Don't let something like that get in the way of getting started in screening or in getting to treating your patients. So
cool.
Yeah.
Any other questions?
No, we hit them all the way through. So
Sweet.
Yeah, we're good to go.
Okay.
With that, guys, thanks for attending. You guys are free to go. And the CE link is in the chat. We'll leave this open for a minute or two more and wrap up. Thank you so much. Have a great night.
We didn't even get the question if we're in the same office or not tonight.
I know. Yeah, we're not. I mean,
we're not.
Same building. We've got a concentric theme, but we are not in the same room.
Someone smarter than us picked the colors and the theme for the office.
Mm-hmm.
Most people who know us would absolutely believe that. And that
right.
makes sense. Hey, you asked the question, what is your favorite thing coming up about fall?
I'm a big fan of like hot drinks. So now I get to not have people look at me funny when I'm drinking hot black coffee in the middle of 115 degree summer. So I think it's just the lack of judgment associated with my drinking habits.
Feeling less weird. Okay.
Yeah, it's going to be good. So we don't see any more questions, guys. So if you do have any questions, please reach out to us. You can respond to the email you got the confirmation for. And like I said, that CE link is going to also be in your email in just a moment here. So we'll see you guys at the hopefully on the course. Have a great day.
Have a good night, guys.